Hi, everyone. Welcome to another session of Virtual Global Spine Conference. It's my real honor to have here tonight Dr. Lucas Aurich, who's currently an assistant of neurosurgery at the University of Rochester in Western New York. Dr. Aurich will be speaking tonight about cervical open door laminoplasty, indications, techniques, and outcomes. He did his medical school training in Brazil and then subsequently went on to do a complex spine fellowship in Germany, and then was actually on faculty in Brazil for several years before coming back to the stateside to do a complex oncologic and deformity fellowship with Dr. Udi Mendel at Yale University in New Haven, Connecticut. So I'm going to hand over the reins to Dr. Aurich, and once again, it's fantastic having you here today.
Thank you so much, Dr. Gogan. It's my pleasure to come here today and speak about cervical open door laminoplasty. That's a technique that I like a lot, and I'm happy to share my experience with this technique. So just to tell you about a little bit about me. So as Dr. Gogan just spoke about, I worked in Brazil for 8 years as an attending, and specifically in this hospital, the Serra Hospital in Brasilia, which is a large referral center in Brazil for complex spine. And in this hospital, we have a large number of open door laminoplasty. This is when I was there, I did this research. So we had about 600 cases at that point, and now they have 1,000 cases. So hopefully 50 to 70 cases a year. And I'm happy that when I moved here to University of Rochester, Dr. Silberstein is a great faculty here, a senior faculty at the Department of Neurosurgery. He also has a great experience with laminoplasty with these two publications that I will mention later. So basically, the open door laminoplasty is not a new technique. It's a little older than me, actually. So the first this description of this technique is Dr. Hattori Anomaya from Japan. So we have a great contribution from the Japanese Neurosurgery Society in this technique. So the first one was a Z-shaped laminoplasty. The open door laminoplasty was then invented by Hirabayashi in 1981. And in 1982, another similar technique, the French door laminoplasty. So in Japan, they have also a lot of patients with ossification of the longitudinal ligament, and this technique is very good for these patients. That's the description of the open door laminoplasty by Hirabayashi in 1981. So if you take a look here, he did a laminoplasty. This is the description of our C2 to C6 laminoplasty. At that time, he used to do an open door, and he used to keep the door open with these stays sutures here between the spinal process and the facet joint or the paravertebral muscles, the size of the hinge. The problem of this suture techniques is that sometimes patient will lose the open door and they can have more spinal cord compression over time. So in 1996, this is a publication from Dr. Crocker from England showing the open door laminoplasty. So similar technique with Hirabayashi, but now using the titanium mini plate stabilization. You can see here, it's the same technique. So we do an opening the hinge side, we open the door, and then we keep the door open using these mini plates. So basically, the surgery for open door laminoplasty is for patients with multi-level cervical spondylotic myelopathy. That's a great indication. And also patients with OPLL, as I mentioned before. So the anterior surgery for these patients are pretty demanding. So the posterior cervical, it's a great option for them. There are two things that are important in order to do the laminoplasty that I'll mention later. One is the preserved cervical lordosis, or at least to have a straight spine. So patients with cervical kyphosis is not a good indication for this method. And also to have a stable spine with no major angle or translational deformities.
Lucas, I have a quick question for you. So the classic teaching is exactly what you described, that a patient should have at least a straight spine or very reasonable cervical lordosis. What are your thoughts about measuring the T1 slope before these cases? I have come across literature in the past after I had to do a revision for a post-laminoplasty kyphosis on a patient from an outside hospital years ago. And so I started doing some research into this, and I saw that there was some correlation with patients having early failure with laminoplasties and also laminectomies who not only had loss of cervical lordosis, but also had a very high T1 slope. I'm curious what your experience is with that parameter.
Yeah, that's a great question, Dr. Logan. So basically the patient with high T1 slope, they need higher lordosis, right, to keep the balance. And also they tend to have more loss of lordosis after laminoplasty. So I think it's a very important thing to keep in mind. Of course, if the patient has a good cervical alignment overall, I think it's pretty reasonable. I would be concerned more on the patient that has the C2 to C7 SVA more significant in these cases, so I would be more concerned. But it definitely is a measurement that we need to take a look and keep an eye on this patient. That's a great question. So basically the advantage of the laminoplasty, of course, we can have adequate decompression of the spinal cord without the removal of the posterior elements. So it's a technique that we have a lot of preservation of the posterior elements. And if you compare to the laminectomy alone in the past, we would avoid kyphosis and instability. Also, we reduce the formation of the post-laminectomy membrane that can cause arachnoiditis and restenosis. And of course, I think one of the factors, if you compare the laminoplasty with the posterior cervical decompression and fusion, we can have a motion preservation. Of course, some patients will lose some of the range of motion, even with the laminoplasty, but it's of course not compared to the fusion itself. So as I mentioned before, one important factor here is the local kyphosis. So if a patient has a local kyphosis, in this study here, they retrospective evaluate more than 100 patients who did laminoplasty for cervical spondylotic myelopathy, and they did the JOE score evaluation 2 years after surgery, and they found that the highest risk of poor recovery was the local kyphosis exceeding 13 degrees. So of course, if you do them if you see the example on the X-ray here on the right side, the local kyphosis is a significant factor for the bad outcome. Another important measure is the K-line. So basically the K-line was first they developed it for the patients with OPLL. So basically it's a measurement between the middle of the spinal canal at C2 and in the middle of C7. So the K-line is positive when the OPLL does not exceed this line and is negative when the OPLL exceeds this line. So basically this line we measure both the size of the OPLL and also the kyphosis of the cervical spine. And if the K-line is negative, so the recovery, at least in this study, was less significant in the patient. So recovery rate for 13% in a negative K-line versus 66%. And the ultrasonography also showed that the posterior shift of the spinal cord, which is very important for these cases for the cervical laminoplasty, was insufficient in the K-line negative group. So another measurement, so basically the K-line was using the X-rays for OPLL. So the modified K-line you can use the MRI doing the same measurement in the middle of the spinal canal at C2 from the middle to the middle of the spinal canal of C7. And if you have a compression of the spinal cord that is, for example, less than 4 millimeters from the K line, so also you can have less a unsatisfactory recovery for this patient. So it's an important measure that you can use basically in MRI or X-ray, and it's something that can help us to decide if the posterior cervical laminoplasty will help the patient. We'll talk a little about now the technique. So basically the position of the patient, you can do a cervical flexion here to have a better exposure. Also, by doing a flexion, you can have indirect decompression of the spinal cord. Now I usually do with neuromonitoring this type of cases, and you can see the anti-train here of the bed. Today I also use the Jackson table and the level to have a better position of the head. And that's the picture here from my previous practice in Brazil. So the technique, basically, we need the midline posterior exposure, the subepirosteal dissection out to the mid portion of the lateral masses. We don't need to go much more lateral than this, as you do for posterior decompression and fusion. One thing it's also very important is try to preserve the muscle attachments of C2. I will show you some different techniques that you can do a C3 laminectomy instead of doing a C3 laminoplasty. But the key is, of course, sometimes you need to take a little bit to do undercutting of C2, depending on the case. But if you can preserve the attachments of the semi-spinalis muscles here, you can have a better outcome after surgery regarding the neck pain. Also, another thing that's important is the preservation of C7. I did a lot of patients, a few patients in the past with also C7 laminoplasty from C4 to C7. Nowadays, I tend to be to preserve more C7, and when I need to do a decompression at that level, I try to do a better undercutting laminectomy to preserve it. And also, of course, try to preserve the posterior ligaments, the interspinals, the supraspinals ligament, and the interspinal muscles too. The good thing is about this technique is the preservation of the posterior elements. So as better as you can preserve, it will be good for the patient. Here, so the first step after opening, I usually do the hinge side trough preparation. So the technical detail is to go between the lamina and the facet joint here. I usually match drill or sometimes just a diamond bore, 3 millimeters to do the trough on the hinge side. And here, and then I move to the other side to do the open side trough preparation. So removing of the dorsal cortex, cancellous layer, and ventral cortex, and the left and the open side. Also use a match head drill, diamond drill, and Kerrison Ringer. So after using the drill, I like to use a Kerrison 2, sometimes a Kerrison 3 to keep open lamina by lamina, going from caudal to cranial. And another thing that's important here is the side choice. Sometimes if the patient has a radiculopathy and you're planning to do a foraminotomy, so it's better to do the open side, the same side that you need to do a foraminotomy. Also, you need to check the axial cuts of the MRI to see where is the worst compression. And of course, if it's similar, usually go from the left side. I'm right-handed, so usually it's better for me and usually easier to do from the left. here just showing how the intraoperative view of the open door laminoplasty. So as I mentioned before, I like to use the caisson here underneath the lamina to crack the other side and keep it open. Then you just need to remove some of the yellow ligaments that will be connecting here the side. And of course, sometimes you need to do, even before the laminoplasty, the undercutting of C7 or C2, depending on the side. Okay. And for to keep the door open, also I always use the mini plates. In the past, I used to use this cranial facial plates for fixation. We basically have this, just need to bend it a little bit. But nowadays I use more this centerpiece laminoplasty. So basically, you can hold the lamina here and have a lot of instruments to try to keep the lamina open, and it's easier than the cranial facial plate.
Lucas,
Yeah, sure.
so sorry, do you ever use an ultrasound if you have a large enough window just to verify the magnitude of your decompression, or is that not really practical with the current probes that we have on the market?
I think that if you have a smaller one, could be practical, and maybe in the middle portion of the laminoplasty. For example, if you do from C3 to C6, maybe 4 and 5, you have a better window. I never did it, but I think it's interesting. But I never did it before. Great question. So basically here showing you how to can do the measurement with the trials and put the lamina, holding here the lamina on the other side and put the screws. I think it's a very good technique for to keep the door open. And here just showing 2 examples here in the past, as I do in Brazil using the other mini plates. We just need to do some bending there to keep it open, and now with the new ones, the case that I did recently. And also, as I mentioned before, we can remove the ligament from 6-7 here. We have some compression here, and also 2-3. It's important to have a big opening there and address the preoperative image to see how much up and down I need to go. And here with this mini plate fixation, also sometimes the lamina and the hinge side can get loose, so you can use this hinge plate just to keep it more safe here on the other side. And some authors prefer to use also a bone graft in the middle. I usually don't use it, but it's also an option and of the preference. Here just showing some examples of cases. So this patient, 48 years old male, progressive tetraparesis and Aurich 3. So you can see here a multi-level spinal cord compression, severe spinal stenosis. See the T2 signals in the spinal cord here in the middle. This patient had a good lordosis here in the X-ray. It's more rectified in the MRI, but just showing here. So we did a C3 to C6 laminoplasty. You can see how nice decompression of the spinal cord and sheet of the spinal cord you can see. Here showing the ampliation of the laminoplasty of the CT and the sagittal and the axial view. When I see these patients, the post-op imaging with the laminoplasty, if you compare to the patients that we do, anterior for decompression, I usually, you see much more room there, and I think it's a very nice technique for myelopathy. And also sometimes if the patient has both posterior and anterior compression, sometimes they have big disc herniation and multi-level compression. I think it's better to begin from the posterior because it's safer, and then you can go anterior to do maybe a CDF or a multi-level CDF. But for posterior anterior approach, I think it's better to start with the laminoplasty, and then I can do a smaller surgery in the front.
Lucas, have you ever used a laminoplasty in a situation of like a trauma, central cord syndrome, where biomechanical stability should be maintained? Like, I think the last case you showed, was that a central cord case?
Yeah, it wasn't a trauma case, it was more progressive.
Okay.
But I used in the past for central cord, the patients with, and they have central canal stenosis and a minor trauma, right? And they have the central cord. So if it's a minor trauma with no instability, no fractures, nothing like this, I think it's a good indication.
Right.
Yeah, definitely. And also this patient here, for example, had a prior ACDF in the past, where you can see still severe spinal stenosis, was operated in an outside hospital, and got worse with severe worsening of the trapezosis and Aurich 5 already. And you can see how good is the decompression. In this case, I did just from C4 to C6. I usually go from 3 to 6. But in this case, just by doing 4 to 6, you can see a nice decompression and the shifting of the spinal cord. And this patient I want to show even with a more straight spine. This is a young female of few months of symptoms, Aurich 3, and also we can see here in the CT a nice decompression of the spinal cord. Of course, in this case, because it's very straight, you need to keep a better eye on her regarding the progressive kyphosis, but she did pretty well. I followed her for about 2 years, and she was doing pretty well after surgery. So, as I mentioned before, one of the concerns of the laminoplasty is that neck pain, the post-op. Some study have shown, this is an example of trying to preserve or more the muscles with this technique. So these authors here, they used to do like a French door laminectomy, different from the open door, but instead of doing the C3 laminectomy, doing the C3 laminoplasty, they do the C3 laminectomy in order to preserve more the muscles attachment at C2, and they found less neck pain in the first days of the post-op in these patients. So I think it's a nice technique. There are multiple different, you can see in the literature trying to preserve more the deep extensor muscles in the back. This is another story from Japan, so you can see the preservation of the muscles, and then they do French door laminoplasty. I think it's much more technical demanding, but they also found significant good impact in the cervical the pain in the post-op. There are different techniques that you can try. This is the regular one, the open door. This group here tried also preserving the muscles in one side, or you can do the French door in the middle, preserving the musculature. A lot of different techniques trying to preserve the muscles and improve the pain in the post-op. This study did show some improvement in the first days, but not in the 6 months after laminoplasty. So I think it's much more technical demanding, and I do feel that the open door laminoplasty, the patients do pretty well, even in the classic technique regarding the pain. This is a nice study from Dr. Real from New York. So he basically evaluated a lot of studies that try to preserve C7 or C7 and C2. Most studies, mostly retrospective studies. There was just one randomized controlled trial that didn't show any difference between the techniques. But they do feel that the preservation of C2 and C7 based on the studies result in reduced post-op pain compared to when you do detach the muscles at C2, or you do a C7 laminectomy. So I think, even when you do the traditional technique without the C3 laminectomy, we always try to preserve the muscles and to have a better outcome. And also by doing the regular technique, you also preserve the posterior elements, the ligaments, and I think the results are pretty good. Now talking about the clinical outcomes, I want to show first here the results from the University of Rochester here. So this study was published in 2010 with 40 patients undergoing laminoplasty for cervical spondylotic myelopathy, with the average follow-up 32 months. So in these 40 patients, none of these patients had perioperative kyphosis. You can see the length of stay in the 2 to 3 days usually. None of these patients developed kyphosis in the post-op. Improvement of the symptoms were 90% of the cases, and 4 cases were unchanged, but no worsening. And this is very interesting too. They did an evaluation at that time about the costs. And if you compare, for example, with the laminoplasty itself by this company, by Medtronic, from comparing to the anterior and to the anterior cervical fusion to the posterior cervical fusion for a hypothetical C4 to C6 fusion, the cost would be 3.5 or 2 or at least 2 times higher with the other technique. So it's a technique that can bring less costs to the system. Also, the study here from University of Rochester, both the orthopedic and neurosurgery team, with 105 patients that underwent laminoplasty from 2011 to 2022. They evaluated the complications in these patients and also the radiographic parameters. You should take a look here at the population, and the surgical time was in about 2 hours. They had a total of 4% of minor complications, the intraoperative complications, 9% of perioperative complications, including urinary retention, infection, 1 case of C5 palsy, and the delay of complications occurred in 8 patients.
Lucas, what's been your experience with C5 palsy in laminoplasty? Just out of curiosity, have you noticed that there's a decreased rate of it, or is it not matter whether you do traditional laminectomy versus laminoplasty in patients specifically who are very tight at C4, C5?
Okay. Yeah, I think is the key to look for C4, C5 and the foramen in these patients, right? The incidence, I'll go over a little bit it in the next slides, but the incidence it range a lot. The experience at SARA in Brasilia is less than 5% in the 1,000 patients. I will discuss a little bit about the C4, C5 prophylactic foraminotomy for these patients. The first case I did it, of a patient that have 4-5 stenosis, asymptomatic, and was my first patient I had C5 palsy. So I don't do it as a routine, but it's something that we need to look. If you see in the literature, for patients with myelopathy, the incidence of palsy, it's kind of similar from the anterior to the posterior decompression. but it's hard to say, we don't know the cause already. We think it's more related to the narrowing of the canal, and when the spinal cord shifts posteriorly, you have this stretching of the nerve, but could be another causes associated with this. But it's something that we need to to look very carefully, especially the C4, C5 level. This so just talking about the complications. So in these 100 patients, 3 patients had minor durotomies, intraoperative, and 1 C4 broken ridge. Here, the layer complications. 1 patient developed a severe kyphosis that required combined anterior-posterior approach. 2 patients. 1 patient was operated due to residual stenosis, and 2 developed nuanced cervical stenosis. Also, the results long-term for laminoplasty, they are pretty good. In this study, they evaluated the 10 years follow-up after laminoplasty, and most patients had a good maintenance of the neurological recovery. The mean pre-op JOA score was 9.1, and the final follow-up was 12.8 in both patients, with the patient with OPLL, and a little better in the patient with the cervical spondylotic myelopathy. And the recovery rate was better in the patients less than 60 years old. Talking a little bit more about the C5 palsy that we just mentioned. So the etiologies of this has been the tethering effect of the spinal cord nerve. And also another possibility is the reperfusion injury of the spinal cord. Some studies have evaluated the T2 spinal cord signals at C4, C5 as an effect too. So when you do the decompression, probably the reperfusion would be a cause for the C5 palsy rather than the tethering of the nerve. The incidence in the literature is from 5 to 17%, and no significant difference when you compare the anterior and posterior cervical decompression in patients with myelopathy. 92% is unilateral, and the majority of the case will get better in 1 year. So as I mentioned before, the C4, C5 foraminal stenosis will predict the C5 palsy after the laminoplasty. In this study, they have 80% of C5 palsy in 100 cases, and the diameter of the C4, C5 foramen was the only factor that they could find as a correlation for this after laminoplasty. So they suggest that the stenosis is one of the best predictors for the palsy, and it could be related to the reperfusion injury after the surgery. And this study was also very interesting. So they compare the efficacy of the prophylactic foraminotomy when they do the open door laminoplasty. So they evaluated 140 consecutive patients from 2009 to 2010 that they did laminoplasty, to previous patients that they didn't do the foraminotomy. If you take a look here in the results, the incidence was significant. So they had 2 C5 palsy in the the prophylactic foraminotomy group instead of the 9 in the non-prophylactic foraminotomy. You can see that there is more operating time for these patients, and the results were significant. Of course, they did. It's a retrospective, prospective, but evaluating 2 different times. And this is interesting study show why does the C5 palsy occurs even after the prophylactic foraminotomy. So just discussing, of course, because even when you do the foraminotomy, you can have the palsy, and maybe the T2 spinal cord, if you evaluate at the C5, C4 level, could be indicated of it, not just the foraminal stenosis itself. As I mentioned to you, was my first case I did the prophylactic was the case that have the C4 palsy. So I stopped doing it, and I didn't have any other so far. But I think it's a interesting discussion. Another concern of the laminoplasty, of course, is the development of kyphosis in the post-op. This is a study that showed that in 85 patients, they had 10% of the patient developing kyphosis. The major factors that they saw was the lordosis angle before surgery less than 10 degrees, and also the kyphotic angle during flexion large and the lordotic angle during the extension. This is I think it's a little older study. And after it, we have much more understanding of the cervical alignment methods. And as Dr. Gogano mentioned before, the T1 slope has been reported the most important factor affecting the cervical alignment after the laminoplasty. So basically, patients with high T1 slope, they will need usually, and they'll have higher cervical lordosis, but they also have higher risk of loss of lordosis over time.
So, Lucas, why do you think that is? I'm just curious. Do you suspect that this is a muscular phenomenon, or as we all get older, most patients, it almost becomes physiologic, develop a greater than normal T1 slope, as in higher than 30 degrees, and even in patients who have a commensurate amount of cervical lordosis, just by virtue of taking down some of that paraspinal muscle, despite leaving the midline ligamentous structures intact. Do you think those patients are at a higher risk, maybe the elderly, just because they don't have as high a volume of robust muscle? The patients, and there haven't been a lot, but the patients I've seen that I've had to revise in the past that have had post-laminoplasty kyphosis have usually been elderly individuals. It's not the young individual with robust posterior paraspinal musculature.
Yeah, that's a great point. Yeah, and of course we don't know because usually the patient will lose the lordosis even without surgery over time, right? And we are comparing, and even when they lose lordosis, I think most of the patients will not need surgery for correction. So that's another important point. But I agree with you that probably the muscle detachment that you have, especially when you go down to the C7. So I think it's important point to try to preserve the spinal process of C7 with their muscles attachments at this level. And but I agree that probably the musculature and I think it's very important to, if there is a high T1 slope and the SVA, the C2 to C7 SVA is also high, I think it's probably, you need to, even if the patient has a good lordosis, I think I will try to avoid the laminoplasty or see if there's a better option for this patient. But that's
Anything you do with your closure at the end? I'm just curious. I know like Dan Rue does this very meticulous closure where he places 100 sutures in. I'm just curious, anything different that you do during a laminoplasty as opposed to any other type of posterior based approach?
No, I just a regular closure. I don't do much different there. I just close the fascia with ovicrules, multiple sutures. It's more important layer there, and then yeah, nothing much different. I always put the drain, of course, the concern of the post-op hematoma, but no, nothing different than this. A great point. And This is a very important, interesting study, also discussing the cervical kyphosis post laminoplasty. So they follow 100, almost 200 patients over 1 year, and 10.8% of these patients developed kyphosis in the post-op. And the logistic regression analysis, they found that the SVA, the C2C7 SVA, the T1 slope, and the number of the facet joints that was destroyed was the main factor that caused a kyphosis in the post-op. I think that's a very important point.
So what constitutes facet joint destruction?
Yeah.
Being the capsule, or is that drilling?
Yeah,
I'm always trying to teach my residents to preserve facets when we can, but
yeah.
it's obviously a lot harder in the cervical spine because they're so narrow.
Yes, yeah, I think it's important, to try to not expose all the facet joints, especially in the laminoplasty. Try just, especially the hinge side, you don't need to expose too much, but at least half of the joint in the open door side should be fine. And of course, if you can try to preserve the upper level, C2, C3, you don't need to go very lateral at that point. And also the muscle preservation, right? I think they are key in the laminoplasty. But I would say that basically, in my experience in Brazil, a lot of patients that underwent laminoplasty, some of the patients who developed a little kyphosis, we have few need for surgery for kyphosis in this patient. I think that's the key. Okay. I think it's probably my last slide here. Just for conclusion, so the laminoplasty, it's an effective surgery for spinal cord decompression. It's a fast surgery and not technically demanding. The good point of it, it's a mobility preservation. I have a sense, if you compare to the posterior decompression and fusion, you can have much more adjacent level disease, and maybe the need for reoperation down the road should be much higher than the decompression with fusion itself. The surgery has low complication rates and good neurological outcomes. But of course, the adequate evaluation of the sagittal alignment is very important to decide if the patient will have a good indication for it, using both the T1 slope, the angles, and the K line, and the alignment is the key to have a good outcome with this surgery. That's it. Thank you.
Lucas, thank you. That was fantastic. This was a really great review of laminoplasty. We've covered just about every topic multiple times on Virtual Spine since 2020. I don't think we've talked a whole lot about laminoplasty, so this was definitely a home run lecture that you just gave. So thank you. I'd like to open up the forum to see if any of the audience has questions. So please put them in the chat box. In the meantime, I do have a few additional questions for you.
Okay.
So my first question is about the non-traditional laminoplasty, meaning let's say that you have a 33-year-old female that's got a meningioma, schwannoma spanning C4 to C6. And is that a patient that you would consider doing maybe a non-traditional laminoplasty for, as in you do a laminectomy, but at the end, you take a lobster tail, right? You preserve all the interspinous ligaments, and at the end of the operation, basically just tether it back to the spine, maybe place some proline sutures to the interspinous ligament above and below. Do you ever do anything like that for a non-traditional situation, aside from degen disease, like a tumor?
Yes, I always do for intradural tumors, even intramedullary tumors. I like to do it. I think you need to, of course, you do the opening both sides, and I like to close with the mini plates too, like the hinge plate that you have, a smaller one. You don't need to do like an open door, but I think it's a good preservation technique. The only concern that you need to have is mostly in the transitional areas. For example, if you go more than 3 levels, for example, at C4 to T1, So this patient has more prone to develop kyphosis post-op. So we need to keep a closer eye on them, and maybe they'll need like a fusion in the future. But I always try to do the laminoplasty for this type of lesions, especially in the cervical and thoracic spine, usually.
So even though you're basically disconnecting the rostral and caudal levels from the laminectomized levels, do you still feel that there's some biomechanical benefit to actually putting the spinous processes with the cut interspinous ligament back and just tethering it? Do you find the benefit is just the fact that the paraspinal muscles will eventually reinsert to those
Yeah,
spinous processes?
yeah, I think that the biomechanical is probably not the best reason for that, but we also have the reason if you need to go back there, you have the lamina intact, so it's a little easier than just go straight to the laminectomized level. Some study have shown also the better outcome regarding the CSF leak. So when you do intradural surgery and have a lamina above it, they have a lower risk of CSF leak. The the results regarding the post-op kyphosis, if you go to the transition level, I think that laminoplasty alone will not help. But I think it's better if you get a preservation there and it's a protection for the scar tissue formation, the post-laminectomy membrane. So I think it's a good reason to try to do it.
What about your thoughts of doing laminoplasties outside of the cervical spine? Do you ever see an indication to do a laminoplasty in the thoracic spine or maybe at the TL junction in a younger type patient?
Yeah, I don't think, I never did it before. The problem of the thoracic spine is the of course the kyphosis, right? The thoracic spine is kyphotic already, so we will not have the benefit of the shifting of the spinal cord posteriorly. And yeah, we did in the past some laminoplasty for patients for selective rhizotomy for spasticity. In the hospital in Brazil, we used to do the laminoplasty, just open it and put it back. It was more in the thoracolumbar area, but not for decompression purposes. I don't think it's a good indication for thoracic or lumbar usually.
Yeah, no, I agree because of the fact that there's obviously thoracic kyphosis. I was just curious more about the TL junction. The reason I asked is a few years ago, I took care of a 12-year-old kid who had a multi-level lumbar. He had a myxopapillary ependymoma. I think it spanned about T11 to L3. It was quite large. And I did a laminoplasty on him, and he did fantastic neurologically. But about 3 months
Yes.
after surgery, we brought him back to clinic and I got some upright x-rays on him, and he actually had some kyphosis at the TL junction, completely asymptomatic, was back to
Okay.
school playing sports. So I actually
Yeah.
put him in a Jewett brace for a few months, and he maintained some alignment, but it was never got back to what it was before the
Okay.
operation. So I would maybe in select patient populations that are a little bit more prone to that, like kids who are still growing, maybe it would be a benefit to potentially do a short segment fusion in those patients to
Yeah.
TL junction kyphosis, because even with the laminoplasty, he still kyphed. Again, didn't require
Okay.
operation, but you have to worry about what's going to happen as
Yeah.
they continue to get older at the junction.
Yeah, that's a great case. Yeah, but unfortunately, I think that the transition in the laminoplasty for the biomechanical reasons doesn't help too much, right?
Right.
But there are other reasons that I think it's a good indication. Yeah.
Another curiosity question I have for you is your thoughts about doing an over-the-top decompression versus a laminoplasty. So something I've been doing a lot of lately is I've actually, because of our mutual friend Carlos Goulart, I met up with him at spine section last year in Vegas, and he said you need to start doing more metrics cases, right? MIS tubular
Okay.
cases, because I would just use a McCullough and do my MIS that way. So I do a lot more metrics cases than I used to, aside from
Okay.
my deformity and oncology cases. But in the cervical spine and even thoracic for select situations, I've kind of thought about doing, a midline sparing laminectomy, essentially, where you do a bilateral decompression from a unilateral approach, and you essentially reach over to the contralateral side. Now, I know that's a very well-described technique in the lumbar spine, but not so much in thoracic and definitely not in cervical. So I had a guy with multi-segmental OPLL a few months ago, and he was adamant about not having any metal in his neck. So I said, why don't we try an over-the-top decompression? It actually worked quite well. We got a post-op MRI scan. I thought it looked great. Technically, it's a tough operation to do.
Yeah.
You obviously have to reach to the opposite side, but we've got these ultrasonic bone-cutting side shavers now that we can use, so we're not digging keratins into the canal. And I'm curious what your thoughts are about an over-the-top decompression in the cervical spine, where you essentially leave the midline intact, you leave the contralateral paraspinal muscles intact, and you just approach it from one side and you just undercut the SP.
Yeah, I think it's a great technique. I'll tell you that I don't have too much experience in the cervical spine for it. I do a lot for lumbar spine, of course, but of course, I think the most care is about when you go to the other side, right? Because when you do it to the lumbar spine, you need to push the stickle sac and go to the facet joint. But since the cervical spine, you're dealing more of the central canal stenosis, I think it's reasonable, right? So I think it's a great option. A lot of people are doing endoscopically too, right? Doing the central canal stenosis. I think it's probably, it's an extra step. You have a lot of irrigation. You need to take care about the pressure of the water there. But I agree. The cervical spine is a good option. I personally don't have much experience in doing it. I have a little concern of the spinal cord, but using the right instruments and take a lot of care with the other side, I think it's perfect.
Yeah, I think like with anything, the key to maintaining stability really is keeping the midline tension band as intact as possible. But to your point, it's not easy reaching over to the contralateral side. And for some of these cases, I've used it's the Sonopet, and it has a side ultrasonic bone shaver, and you can actually hold the blunt side, the non-functioning side, against the dura. It doesn't heat up, and then
Nice.
you basically shave the the contralateral part of the bone. So it's a nice tool that we have in our toolbox for a case like that. Doesn't look like there's any other questions in the chat box. If you don't have any other comments at this point, I think we'll close up and we'll look forward to next week. But we really thank you for being here, Lucas. This was an absolute all-star lecture that you gave. This is going to be recorded for anyone that missed it, and we look forward to seeing everyone next week. So just keep an eye on LinkedIn and Twitter, and we'll be seeing what's up for next week. Thanks again, Lucas.
Perfect. Thank you so much for the opportunity.
All right, guys. Have a great night, great morning. See you next week.